All right, get your questions ready because we have an incredible panel. We've got 4 doctors now, and we are going to buzz through these questions that we have so we can get to yours as well. But, you know, we really want to kind of set the stage on stories, talk about hormones and how they impact mental health, because that is so important. Talk about diagnosis and treatment, and then some more Q&A. But we really want to answer the question why we don't feel like ourselves these days, you know, and I think that that's really broad but really important. And that's kind of it at the end, right? Is that what we want? We just want to feel normal, whatever normal is. So let's go ahead and get started. 4 amazing panelists right now, and I'm just going to give you a quick bio of each one. And if you guys want to wave whenever I say your name, Dr. Alexander, a psychotherapist running a private mental health practice in the Dallas area. Dr. Kingsburg, clinical psychologist, professor at Case Western, Division Chief of Behavioral Medicine at University Hospitals, Cleveland Medical Center. Dr. Jeffers, nurse practitioner with a doctorate in nursing and co-director of the Center for Midlife Health and Menopause at NYU Langone Health. And Dr. Weinstock, a New York psychiatrist in private practice with a focus on women and mental health during key reproductive transitions. So let's see, Dr. Alexander, let's start with you. Can you begin by sharing your story?
Yeah, I was forced into menopause at 45 because the fibroid tumors had taken over and I wasn't well informed. The doctor actually told me on the operating table while I was under anesthesia, going into the room, he asked me, he hopped up on the table and he said, "So are we doing a full or a partial hysterectomy?" And I said, I didn't know that there was a choice. And so he said, if I do not take your ovaries today, we may be in the same position about 2 to 3 years from now. And so I said, I don't ever want to go through surgery again. Let's do a full hysterectomy. So I was not informed, did not realize all of the things that came with having a full hysterectomy. And there you go.
And your story is not an uncommon one, because we have heard a lot of women that, I mean, when you're laying there as vulnerable as can be.
Right.
And what's the right answer?
Right. Very anxious at the time. Had actually witnessed my mom going through surgical induced menopause when I was a kid. So I knew I did not want to have a hysterectomy, but at that point, my doctor said I needed to do it.
Well, thank you for sharing your story, because it's one that so many of us can learn from and be aware of, but probably, you know, some people can relate to. Dr. Kingsburg, let's talk about this, the sudden loss of hormones through surgical menopause. And somebody did bring up surgical menopause and chemotherapy a little bit earlier, but let's talk about that, because it is likely, obviously, to impact mood and versus a gradual loss.
Well, sure. And in the last panel, you heard that loud and clear. If you lose your ovaries and have a sudden loss of hormones that were working just fine, that's going to have a considerable effect on all kinds of things, but in particular your mental health. Having that trauma on the operating table is yet another story. But we now have the question of take it or leave it, is the question that many surgeons have. When do I take those ovaries? And we actually do have guidelines that would say absolutely not at 45. Usually not at 50, maybe at 65, and Dr. Minkin would say that's too young anyway. But that certainly is way too young, and the circulating hormones that change, you know, everything is in the brain, and hormones absolutely impact neurotransmitters that will impact your mood. So if you are prone to hormone-related mood problems, that's going to happen.
Dr. Weinstock, let's talk about how and why hormones impact mental health. You specialize in reproductive mental health. What is that?
So reproductive mental health, or reproductive psychiatry, is really a subspecialty of psychiatry and mental health in general, because it's not just psychiatrists that work on this, psychologists, social workers, nurse practitioners, where we focus on mental health issues, psychological and psychiatric issues that impact women across the female reproductive life cycle, sort of specifically focusing on areas like PMDD, issues that happen, you know, in the week before a woman gets her period. PMDD used to be called PMS. We focus on women having trouble if they're going through infertility treatment. How does that impact their mood, the hormones that they're taking, and just the basic trauma of infertility. We work with women during pregnancy who either have pre-existing psychiatric issues, and they have questions about how to manage them during pregnancies. Are medications safe? What are their options? And women who may develop new problems during pregnancy. We work with women in the postpartum period where you have a very rapid change in your estrogen level, and many women are at risk for developing, if not postpartum blues and postpartum depression, postpartum anxiety, God forbid, postpartum psychosis. And then we work with women in perimenopause and menopause. And in all of these phases of the female reproductive life cycle, we see hormonal fluctuations. And as Dr. Kinsberg said, we know that estrogen and progesterone don't only work on your uterus, and they don't only have a feedback to your hypothalamus to make sure that you go through regular reproductive cycles, but they have impacts on our brain cells in lots of other ways. And so when we have these fluctuations at these different points across the female life cycle, there are certain women who seem to be more vulnerable to developing worsening mood symptoms, whether it's depression or anxiety, new or worsening of what they already have.
So, Dr. Jeffers, I want you to jump into this. How much does the risk of mood problems, how much does it increase during perimenopause into menopause?
Well, I think what all of these issues have in common, and you laid that out so beautifully, is really this window of vulnerability. So anytime there is a hormonal transition, which women have many times during their life, but particularly dramatic at perimenopause, that whole menopause transition is a very spiky time of a lot of estradiol variability. And so this creates a window of vulnerability that's very specific to this time. And what we find is that in early perimenopause, and I think our first panel laid this out so beautifully, in this whole menopause transition, there's early perimenopause and late perimenopause. And in early perimenopause, women, even women who haven't had mood disorders in the past, will be about 1.5 times more likely to develop a mood disorder. And that increases to almost 3 times more likely in the later perimenopause. So that's a really dramatic risk factor. And we know that women who have had mood disorders previously, or women who've had PMS, PMDD, postpartum depression, all of these things, or a history of anxiety and depression at other times in their lives, will certainly have a greater increased risk. So it's a real window of vulnerability.
Okay, and any of you can jump in on this at any time. Here's what I do want to say, and I'm not alone in having heard this story, but when I first started going through symptoms of moodiness, depression, just feeling very not me, the first thing that happened when I went to my doctor, my primary doctor, is I was handed antidepressants. I was handed Lexapro and told to go on 10 milligrams of Lexapro and call me in the morning. And that's what I did for a significant amount of time, and it didn't change anything for me. And I have heard that story over and over and over again. So what does that go back to educating and doctors needing to know more?
It really does, because they're looking for quick solutions. I mean, I think that's our system at this point anyway. And if we don't advocate for ourselves and explain, no, it's not just that, I wasn't struggling with this a year ago, or there's nothing that has significantly changed, they're not going to slow down and listen to us. So part of it is educating ourselves and then educating the clinicians.
Can I jump in? Can I also
Absolutely.
comment that I really wish they would make women-friendly lavaliers, because our fashion doesn't always work. And so it's not working very well on my jacket.
They can still hear you if it's clipped on you.
Oh,
Yeah,
okay.
yeah,
Well,
I promise.
they were like saying you're.
Oh, they
lavalier
weren't
is
hearing
for-
you? Okay.
Yes, they were
All right.
signaling me. So
Sure.
let me just say that in your case, the question is also timing, because you are perimenopausal, hormones might have been a better option for you.
Sure.
Although it is not indicated for depression, it is the teasing out of, are you postmenopausal, at which point hormones will not help with depression, or are you peri and early postmenopausal, at which point it's a fair thing to try, particularly if the SSRI isn't going to work. So it really is a timing issue for that as well.
Well, so let's go to this because this slide it shows a lot of different things that women experience. Their signs and symptoms. Changes in mood, though, obviously one of the first symptoms of perimenopause, correct?
Yeah, I was just going to add that, as I think part of the problem in your case was that nobody took the time to really ask you enough questions. And I know we're going to get into this more, to really figure out, to make a diagnosis. You're coming in so many people go to their primary care doc and say, I'm not feeling well. And they say, here's some Prozac, here's some Lexapro, without really asking what's going on and whether there are more psychosocial issues that need to be addressed through therapy, or whether it's, perimenopausal issue. They would need to be asking you, how often do you get your period? What other symptoms? And without asking that and just throwing an SSRI at you, it may have ended up working because maybe with a big conversation that would have been appropriate. But I think it's that issue that they were talking about before, that we don't have enough time to really explore all of these factors.
Well, let's talk about.
Second, I do want to say it doesn't take a lot of time, even in Dr. Minkin's 20-second visit. You can ask certain questions to really get at, has anything changed?
You're so right.
Right. And that way, a clinician should not be excused from not asking those questions. It is, and we'll talk about it when we talk about sex as well, we want to consider your health and mental health from a biopsychosocial model. There are psychological factors that you reflected on. There are biologic factors, there are sociocultural factors, and it doesn't take a rocket scientist to be able to help a woman who's smart enough to be able to tease out which might be going on. She's more than happy to tell. You just need to ask. So make sure your clinicians are asking, and find another one if they're not.
And speaking of, I just want to interject, speaking of not rocket science, I think one of the most important things women can do is super low tech menstrual tracking, and just keep track of your periods. There are plenty of apps. Start keeping track of your periods if you're not doing it already, and keep track of the symptoms and when the symptoms are occurring around your cycle, and bring that information to your clinician. Because for me, that's where I get a lot of my information, and it's very quick and easy to understand where are your cycles. Not that we have to necessarily see cycle changes first, because we talked about that in the first panel, but definitely looking at mood symptoms around the cycle and what is the relationship.
All right. I want to ask one more question before we move on to different demographics. Dr. Alexander, more on the psychosocial effects of things, the different impact if you lose fertility choices, if it's 40 versus 50 years old when you go through menopause.
So I work with a lot of professional women, and part of the discussion with women who have had children and go into menopause, their response to it is different from women who have not had children. Because when you get to that point, there is a realization that I'm no longer able to procreate. I'm no longer able to birth. I'm no longer able to, have another legacy walking around or what have you. So if you've never had that experience, your level of emotional impact is significantly different from someone who has, 3 grown adults calling home for money every 3 weeks. So it is one of those things that we need to ask them.
That puts it in perspective, right?
It puts it into perspective, right? But when you're working with women behind closed doors, you want to ask those kinds of questions, because their perspective on that phase of life is different.
Sure. Yeah, it makes total sense. Different demographics. Let's talk about this, and if they can have different symptoms and risks as well. So Dr. Jeffers, let me start with you. Hispanic women have a 2.5-fold increase in mood disturbances. Is that correct?
Right. So we can see differences in risk and odds ratios, and differences in the experience of mood issues. And we don't really know exactly why. We think that the racial and ethnic differences probably interact with some socio-demographic factors. There seems to be issues related to education, of course, financial stress. So a lot of other issues that play into this that I don't know that we have teased out yet, but we do know that certain groups are definitely at higher risk, including not just Hispanic women. That's the highest risk at 2.5. Black women as well as Japanese women are also at an increased risk.
All right, let's go on to talk about Black women, because I'm more likely to have incidents of depression, but less likely to seek help, correct?
Right. So when we were talking in the earlier panel about sucking it up, think about this misnomer of Black girl magic, and how it's being pressed in our society to be strong. And that's been for generations. It's nothing new. It's just a different term on it now.
Okay.
And so when they experience those things, it is like, okay, this is just another issue that I have to overcome. And in our community, this is what we say. If white people are experiencing it, we're experiencing it at 10 times that level, because of access to care, information, education, and being informed, and actually openly talking about it.
Right.
Because we've been conditioned, do not talk about what goes on in the home outside of the home. So you still feel alone, and you feel like it's only happening to you, when it's actually the exact opposite. We just need to talk about it.
And then going to ask for care is a whole different issue.
Asking for care is definitely, and because we're not listened to as well, because
Right.
we're expected to be stronger, we're expected to have a higher pain tolerance, we're expected to do all of these things at significantly higher levels than our counterparts of another race. So we're not even asked the questions that women of another race are.
So how do we get started there? I mean, events like this are incredible, but you've got to get into community, and you've got to get into media
on
talking
TikTok.
about it. You got to get on TikTok.
Get on TikTok and talk about it, because that's
I'll
where,
tell you what, you're right,
that,
though.
that 30-second
Yeah.
swipe is,
Yep.
is very,
Yep.
I mean, you can reach a lot of people.
Yeah, you're right. You're really right. I mean, you have to reach masses at this point, because we're so far behind in this. There's no question about that at all. I said earlier, I've been in media for 30 years. I didn't say menopause until a year and a half ago.
Right.
Like that's a sin. That is a sin.
Talk vagina, clitoris, orgasm, the next panel, you'll really get used to it.
Fast forward to that. All right. Some good news. There are some multiple treatment options, and I want to talk about that. Dr. Kingsberg, I think you're going to talk us through the treatment options at a very high level, correct?
Sure. So at the highest level, you have various options, and please don't look at that as this is linear. It really is an individualized approach. There are many non-pharmacologic treatments for mood disorders, particularly if they're mild. But we talked about lifestyle changes for vasomotor symptoms, hot flashes and night sweats, but absolutely for mood. Getting exercise, even changing your diet, having a much healthier, for example, a Mediterranean diet can actually help your mood. Let's not talk about alcohol and other recreational drugs. And then there's cognitive behavior therapy or other forms of sort of behavioral therapies that are evidence-based. We have very good evidence that not only can cognitive behavior therapy help with mood swings and hot flashes, but it can help with so many other of the psychosocial issues. Then there's hormones, or HT. And so we have birth control pills for women who are perimenopausal. We talked about that before, particularly if you're at risk for pregnancy. That could be a real mood downer if you did not want to be pregnant. And then there's menopause hormone therapy. And let's not forget, and Dr. Sock can talk about psychiatric medications. So the SSRIs and SNRIs, selective serotonin reuptake inhibitors, selective reuptake norepinephrine reuptake inhibitors, are very effective for depression, sometimes for anxiety disorders. If you have much more significant psychiatric disorders, you really need to see a psychiatrist to talk about what those medications are. Sometimes it's a combination, back to my psychosocial model. Sometimes psychotherapy is really helpful, and I do this with my postpartum patients. Sometimes pharmacotherapy is going to be really effective, and sometimes the combination is the best treatment of all. It is individualized. It's not a one-size-fits-all.
I'm sorry, a combination of,
Psychotherapy and pharmacotherapy and lifestyle.
okay. Oh, and
Layering.
lifestyle.
I think of it as that layer.
Okay, so I have, Dr. Jeffers, I think you're going to walk us through a case study, correct? And
Yeah,
bringing
absolutely.
a
So-
case study to life.
Yeah. So I can't really read that, but I do remember this.
Do you want this?
patient.
That's all I got.
It's okay. I remember this patient very well because this is so typical of a patient that I would see presenting to our center. And she is a 48-year-old perimenopausal female. She had a prior history of depression, which was always worse before her period. So some symptoms of PMS, even to the point of PMDD. So she did have a history, and she had been in the past effectively treated for her PMDD symptoms with Zoloft, sertraline. PMDD premenstrual dysphoric disorder. It's just really like PMS on steroids is kind of the quick way to put it. But she had discontinued her medication at age 40, I think. And the reason for that is she was feeling better. And then perimenopause hit. And in this case, this patient had previously very normal periods. They were coming every 28 to every 30 days. They were textbook normal. Suddenly she began to experience periods that came like every 21 days or every 35 days. And then she actually went 60 days without a period. So she had elements of both early perimenopause changes in her cycle as well as late perimenopausal changes in her cycle. So she now presents with these irregular periods and hot flashes that are the week prior to her period. But remember now, because her periods are so irregular, she doesn't really know when they're coming. So her mood symptoms are all over the place, and she doesn't understand what's happening to her. And she's really experiencing, she described it so perfectly to me. She said, I feel as though I'm falling off a cliff. I feel myself falling off a cliff. And then a few days later, I'll get my period. So in this case, she had a lot of anxiety. This was part of the cliff falling. And what we did is we worked together and talking about lifestyle, talking about layering. We talked about perimenopause a lot and this transition and the differences in the up and down of the estradiol. And in this case also, and this is where a really thorough history is important, this patient was drinking 5 cups of coffee a day. This is not unusual from what I see. Women are combating fatigue with more caffeine, and they're drinking it throughout the day.
Yeah, no, I'm one of them.
And that really was exacerbating her anxiety.
I want to talk about this. I want to bring lifestyle back into this all the time, because we do talk about hormones a lot, but lifestyle plays a huge part in all of this, in every part.
Right. Part of my search for answers, I went to a holistic doctor. I went to female physicians. One female doctor cried with me and said, I cannot believe you were so misinformed. I finally ended up in a hormone clinic after seeking out plastic surgery to get rid of the abdominal stuff that was going on. And the doctor told me, you're overweight. He said, all of your estrogen, your body is looking for estrogen. So everything you eat, the sugar, is going to your abdominal area. He said, stop eating so much sugar, lose some weight, and then come back. Well, it was hard as heck for me to lose that weight. And I ended up at a hormone clinic, and that's where I got the answers. I was still overweight, but I wasn't as moody. And then I realized I was addicted to sugar. And so now I'm sugar sober, which is
it's a real thing.
I'm sugar sober. It has been 13 months.
Wow.
I'm sugar sober. Yes, I'm serious. Yeah. And I lost 40 pounds. Yes, ma'am. I did 40 pounds. But I didn't stop hormone therapy because I realized that was the catalyst for me having a clear mind to think through my options.
Exactly right.
I was so foggy during that process. No clarity. And being able to help other women, because I was vocal about it on social media, like, this sucks. I can't do what I'm supposed to do. And women were just flooding to my office saying, help me.
Yep.
Mm-hmm.
Okay. Did we hit all that? Do you want to finish?
I just want to add something. In that first case, I think the other thing to be really focused on is that this is a woman who had a prior history of depression.
Okay.
And, I think that there are clues in her story. She had depression, and her depression worsened in the week before her period, which is, some people call it PMDD, we call it premenstrual worsening of depressive disorder. So if you have anxiety or depression as a baseline, and then many women do get worse symptoms in the week before they get their period, as well as then as they go through perimenopause. So I think this woman, she had stopped her Zoloft, and then she got this rush of the hormonal changes, these new hormonal changes, which is a stressor in and of itself. So I think it's important to sort of communicate to this woman what we think is happening. And certainly there's the perimenopausal part of it that's exacerbating things. But we also want to remind her that she has this history of depression, and we want to make sure that the depression doesn't worsen significantly. So this is a person I would absolutely tell to go back on the Zoloft and probably, refer to psychotherapy. I mean, I think there are times where one or the other may be more helpful or more practical for someone, but in my opinion, in an ideal world, both are the best option. So if we can do that, and we can't always, but again, it's this idea of communicating between providers, and I know Dr. Jeffers is able to sort of address all of these different pieces, but sometimes providers aren't. And so making sure that we communicate that.
Talking to each other. All right. The case study 2 is somebody with no prior history of mood or anxiety issues. Dr. Kingsburg, are you walking us through that?
Sure. So in contrast to one who, they're both 48, but first one had a prior history. She's got premenstrual dysphoric disorder or an exacerbation of her depression. This one is new onset. So then we look at the perimenopausal sort of causing her mood changes, and it's probably the hormonal shifts. It's new for her. So she's got irregular periods. She is more irritable. She feels down frequently. When we think about depression, and I think it's important to define depression, depression isn't sad. Depression is flat, right? When you are depressed, you have lost interest in things. You have no motivation to seek things out that you know are enjoyable to you. And that's what women will experience. They're like, well, I couldn't be bothered. And they're irritable. Sometimes they're a little bit, they have some more angry outbursts. She couldn't concentrate. So for her, we have to think back to the question of, do we want to try her on some birth control or some hormone therapy, or do we want to think about antidepressant? Or in my case, I would absolutely want her to have some psychotherapy to work on what are the situations in her life, because is she 48? What's going on in her life that we may want to change in behaviorally to set up some different ways of her living her lifestyle so that she can improve whatever mood we can before we may put her on something else. But I don't want her, and here's where sometimes it goes awry, you don't want her to be in therapy forever suffering with symptoms.
Right.
It's the combination.
Let's talk about therapy for a minute, because I was actually talking to somebody yesterday about this at work, and she said, she's upset and mood. I could just kind of tell some of the symptoms, and I'm not a doctor, but I know what I was through, but she was not comfortable with seeking therapy. And that's a whole other hurdle, and then some people do not have access to that. And so how do you handle that? I mean, some people don't feel comfortable, other people don't have access to it.
Well, the access, thankfully, the only fringe benefit of the pandemic was telehealth. I am now licensed in 35 states. So yeah, so it is better access. Say my postpartum depression patients with babies, they couldn't come to my office. Now I can see them in their own home with the baby right there. So access is better, but you need mental health coverage. Most insurance companies and Medicare and Medicaid will cover it. So there is an access issue now. It's better. It's still not, but the stigma of therapy remains. And so that's part of the education, to be able to say, you're entitled to good mental health. It doesn't mean you're weak. It's not a pick yourself up by the bootstraps and how dare you need therapy. This is a tool to help you become your best self.
Can I interject on that? So this is what I'm so glad we're in a room full of women. Sorry for the guys that are in here. But how many of you go to your annual physician appointments? You go for your well women's check, right? You go to your dentist twice a year, right? Make sure your teeth are looking good. A lot of you have on glasses, so you're going to the optometrist at least once a year, right? When you move into a new city, do you look for a beautician, a stylist, or a colorist, right? You have to get that. So how many of you go to your annual psychotherapy appointments? How many of you check in once or twice a year? So then I ask you, why is your hair care more important than your mental health? When you tell me that you're not going to go to therapy.
But it puts it in
perspective, right?
Right? It's almost
it's
embarrassing to answer
care,
that.
right.
Yes.
I was just going to say, the other thing about therapy, there's a big stigma for sure, but I think there's also a misconception that therapy is like Woody Allen's therapy, where you go to a psychoanalyst 5 times a week and lie on a couch and you're in therapy for 30 years or whatever. And now we know that, there are scientifically proven types of therapy that really work, as well as medications for certain types of psychiatric disorders. And so, there's a ton of therapists out there. Some are good and some are not so good. But I think if you're looking for a therapist, you want to ask them, you want to tell them what your problems are, but you want to also ask them what approach are they going to use and why are they using that approach, and really listen to that, because things like cognitive behavioral therapy or dialectical behavioral therapy or EMDR have been shown to be really helpful for certain things. So I think there is that stigma too, that maybe your colleague had this fantasy of what therapy was, or was embarrassed about what they might have to tell their therapist. And it's really not sort of that polar.
For the most part, it's short term. My goal is to become obsolete. And that is, I managed to become obsolete a lot of times. And then there's relapse prevention. So I like to see people come back every 6 months, every 12 months. And I do I say, you go to your dentist, and I'm much less painful, mostly. And that is really about coming back to make sure that, because they think about it. When they know they have to see me, they'll think about, well, what's going on in my life that I'm not using my tools very well? And that also keeps them on task.
All right, let's hit case study number 3, 56-year-old menopausal woman, newly anxious, sad, tired all the time, sporadic hot flashes, waking up every morning at 4 a.m. and can't get back to sleep.
Well, can we talk about sleep for a minute?
Yeah.
And
Sure.
the impact of sleep and mood. So that's a kind of very bi-directional.
Just 1 second. Can everybody hear? Can everybody
see.
hear everyone? Okay. All right.
So I don't have to hold it up like this.
Maybe
Oh,
we
see?
can crank
Well,
up your mic a little
Okay, so back to my original strategy of holding it.
bit.
Well, look at this nice little menopause puzzle. That is such a great slide because it really shows the interaction of all the potential symptoms and how do you know which one you're going to pick? And I think talking about the layering, you kind of pick out which is the most prevalent symptom, which one started first, and that will help guide how you and your clinician want to go about treatment, right? Because if you are not sleeping, that is absolutely going to put you at risk for a mood disorder or anxiety. On the other hand, I see lots of people who have a depression and then they're waking up at 4 or 5 in the morning with early morning awakening. And they're, well, is that menopause? No, that's the depression causing early morning awakening. So you need to think about that. And trust me, for the weight gain, that would be depressing. And panic attacks are very common, but is that really a hot flash leading to panic? Oh my God, I'm sitting here on stage and I'm about to have a hot flash. Am I really panicking, or is that? So you need to tease out which is which, and women are smart. They can figure that out, and that will help guide you and your clinician as to treatment approaches.
Let's go back to sleep though, because I think that is something to address. And I was actually thinking about that. What does come first? Is it sleep affects mental health affects sleep, or it could be any combination, which is why it's it's a puzzle.
It could definitely be any combination. And like we were saying on everything, it's so individualized.
Yeah.
And I don't think enough of us slow down to figure out what's really happening with our bodies until we're in crisis mode. Everything that happens out of the ordinary is an alert to you that something needs to be reset in your body. But from my experience, if you're not getting enough sleep, something is going to show with your mood.
Yep.
You're going to be more irritable. You're going to be sadder. You're going to have the anxiety. Something is going to show from a lack of sleep. And think of how many people are not getting enough sleep anyway. And then when you go into menopause, it's exasperated.
And then you're down in the coffee, and then you've got the cycle that starts.
Yeah.
Alcohol is really disruptive of sleep. And in my experience with menopausal women, particularly in the last 9 months, we're seeing a lot of women reporting to care that didn't do anything and were suffering during the pandemic with hormonal symptoms and just suffered through it. And now they're presenting to care. And if you are actually checking in with how much caffeine, what's the diet look like, how much alcohol are they consuming? And we're picking up a lot of women who are consuming a lot of alcohol that's really making the situation worse.
So I'm curious, and I don't know about any of you, but does alcohol and caffeine, do they start affecting you differently in these stages than you did when you were 20, 25 years old? I mean, I know for me.
It can exacerbate that
The
caffeine,
symptoms.
because caffeine activates the sympathetic nervous system. When we lose estradiol, there tends to be an activity of the sympathetic nervous system. So it exacerbates that. And then alcohol interrupts sleep. It disrupts REM sleep. And it also has obviously a depressant effect.
And think about red wine. How many of you drink red wine? Okay, anybody notice that they have more hot flashes after red wine and the tannins? Yep. So when you're 20, you might get away with it, but when you're 50, you're going to have a hot flash.
And then that goes to sugar.
The sugar.
The red wine, the sugar, and that
yeah.
increases hot flashes too, or increases the feeling you get with hot flashes? Does
Yes.
sugar do that too?
Exacerbates any blood
All the
sugar.
levels.
The blood sugar levels going up and down and up and down. Yeah.
Let's talk about testosterone. We talked about estrogen. We talked about progesterone. I want to address testosterone and either where you stand on it or thoughts about it or risks about it. So whoever wants to jump in. Do you want to start?
I love testosterone. I'm a patient, and I go every 2 to 3 weeks and get an injection. So
Okay.
You would have to seriously talk me out of taking testosterone for the focus, the energy, the strength, my muscle mass. Like I feel different. I feel stronger mentally and physically. So I think it was definitely a good move for me.
Okay, I'm going to jump in here. As a past president of North American Menopause Society and ISWISH, we actually have some global consensus guidelines on testosterone, and we do know that it can be effective for hypoactive sexual desire disorder. We'll talk about it in the next panel, which is low desire. It is not, there's no indication for any other condition yet. And unfortunately, the injections, which is also going to the idea of hormone clinics, you really need to be very careful. No pellets, no injections. What is recommended is going to be a topical gel. The FDA products for men, because there are no FDA products for women, testosterone products, only for males, but we know they are FDA approved. And so we take those versions. So there's a testosterone gel, and we use what would be 1 day's dose for a man would be about 10 days dose for a woman. Okay, so you've got a little gel that would be 1 day, and that packet should last a woman 10 days. Put it on the back of your calf or on the back of your shoulder, someplace where there's not hair, and what you're trying to do is to increase your testosterone levels to what they are in a premenopausal woman. We are not creating super physiologic doses. We are putting them back in a premenopausal level, right? And for women who think of a little is good, a lot is better, no, we're just trying to get you back. And so if it's working for you, you would know it in about 12 weeks. And after 12 weeks, if it's not working for you, don't do it. You need to have your blood levels measured. Here's where you do want your blood levels measured. Beforehand, it won't tell you anything. There's no blood level that will tell you whether you will be a responder to testosterone for low desire. But once you have been on it for several weeks, you want to make sure your blood levels are in that premenopausal range. Okay? Did I? Sorry.
Complete agreement. I think one of the issues to be aware of is that the injections, and in particular pellet therapy, is very dangerous. And the reason for that is once those pellets are inserted, there is no control over the dose that you're getting. And very, very often, and I'm concerned about the number of patients I'm seeing at our center who have been to clinics and come in with pellet therapy. We can't get the pellets out. And I have had to test hormone levels, which I rarely do. But in this case, I have had to test them, and I find their testosterone levels are extraordinarily high, can be very dangerous for many different things. And it can adversely affect cholesterol levels and risk for coronary heart disease. So I think it's something we have to be very cautious, very careful about. Transdermal. I'm glad.
Well, here's the thing. Mine are very low. I do want to make that known.
Yeah.
We do keep my levels very low, and I get my blood tested every 90 days.
Perfect.
Yes, we are definitely monitoring it. Yes.
That's what you want.
I think it's important to talk about, though, because it is the one thing that is not talked about as much. And so women do, if you're going to somebody that you walk in there and you feel comfortable with, and you feel like they're giving you an answer, you're going to look better, you're going to feel better, you have low testosterone, it's going to change your weight, it's going to change your muscle, sign me up. Without the education, right, about it.
This is really the key, that the theme that we've been talking about is women are desperate. They don't know where to go.
Exactly right.
And they don't know how to get help and what is the right kind of help. And so really that's one of the big issues. And the other issue that we have to be careful of that has already been brought up is the proliferation of products of people making money off menopausal symptoms.
And that's what's going to happen. With us talking about it more, people are going to see this as an investment. They're going to see it as a money-making opportunity. So the more informed we are, the more we can tell our friends and family, like we were talking about, the next generation of women, to say, oh, no, honey, you need to go read the research on that.
Right.
All right, let's talk about this. I want to talk about accessing treatment because I think that that's important. There are barriers to getting help, and I think it's important that we have messages for patients and for women. We're going to start taking questions right after this. But how do you access treatment? Where do you start? If it's very easy for us to say, like, you need to have a therapist, you need to have a gynecologist. But if you've gone to a gynecologist since since you were pregnant or since you were in your 20s, and that's the gynecologist you go to, like, that's what I was doing for a long time. They never mentioned menopause, ever, never. I had endometrial polyps removed 2 different times. And I find that in a lot of cases. Where do you go to start accessing that treatment so you feel comfortable that you're with the right person?
Well, I'm always going to promote the North American Menopause Society. That's easy enough to just go on menopause.org and find in your zip code a NAM certified menopause practitioner. Easy enough. And if your clinician is not asking you about things like hot flashes, night sweats, and vaginal dryness and pain with sexual activity, because we'll talk about that the next panel, then you need to find somebody who isn't busy delivering babies or wanting to do surgery, but and that's part of the other problem with menopause practitioners, they don't make a lot of money off of women because they're not doing all these fancy procedures, thank goodness. And so you need somebody who's willing to be invested in midlife women's health.
I feel more hopeful that we have started this Center for Midlife Health and Menopause at NYU. And it's a university research-based model that we really, as a co-director, I started it based on patient-centered care, based on informed decision-making. And I think that that's really important because we do have the opportunity to collaborate across many disciplines. And I think that that's an excellent model. Is it perfect? It's not. It's a bumpy road, and we're doing something that's new and different, but I believe in the model. So I think models of interdisciplinary care at major academic medical centers is a great place to start. And the beauty of that is it's not a concierge type of practice.
Good.
I mean, women are paying thousands of dollars to go to menopause specialists, and it really decreases access. It doesn't improve access. So we do take all different insurance plans, and I am committed to spending, 45 minutes with my patients. So, as long as we can hang on to those models, and it's not easy, if they're not easy to set up, and they're probably not going to be easy to sustain, but I think that gives me hope for menopausal care.
But I think one of the problems that's happened during the pandemic is that there's such a shortage of good, therapists and psychiatrists and, OBGYNs. It's just so hard to access care because the waiting time is so long. And so that's another problem. You may actually want to get into therapy, or you may want to see a psychiatrist, and there may be 3-6 months before you can. And I think that would be a situation where you may want to go back to your primary care or your OBGYN and explain that to them. They may know somebody, you may have a friend who knows somebody, but they may be able to start the process until you can get to that specialty. Because I agree with Dr. Jeffers. I think that in an ideal model, having collaboration between people who specialize in different pieces of this is the most ideal thing, but it's not always so easy to do that these days.
What medical practitioners can typically help? And if we talk about, we're going to a GP, a general practitioner, OB, I had somebody drew my blood that wanted to, start me on estrogen. What are the medical practitioners that can most likely help?
Your primary care physician, that's always our first stop.
Yeah.
But the OBGYNs
And there are primary care that specialize in women's health.
Yeah.
So that's
Okay.
also, if you're thinking about primary care, think about somebody who does women's health, because it is not the same as men's health. And so, and not just women's health, but midlife women's health. And that's really where you want to narrow that focus, whether it's a gynecologist, and I say OBGYN, but really you want gynecology because OB is done, and or a family practice or nurse practitioner or primary care who specializes in midlife.
I want to just open the floor, and any of you jump into this, but we started this off saying, like, how can I feel normal again, or what's wrong with me, and how can I get back to who I was? That anxiety is real. Anxiety is real. Not even knowing who you were before that is real. Lifestyle plays a huge role. Are you seeing lifestyle, and what parts are we talking about in particular? I assume nutrition. I assume exercise. what parts of nutrition and exercise are you focused on right now in each one of your specialties?
For me, it's the sugar.
Okay.
Especially with Black and brown women, so many of our foods have hidden sugars in them, and then we cook with a lot of sugar. That's just how I was taught to cook.
Okay.
And so like I told you, I'm very vocal about my journey, and losing 40 pounds was a huge, like my audience noticed it and
Yep.
they wanted answers. But I don't think we realize just how much that sugar disrupts our mood and our ability to concentrate and sleep when you're eating a brownie before you go to bed. I mean, that's serious what we're
No, it
doing
really
to
is.
cope. Like, just one of those things we're using.
And how did you start doing that? Because people, I'm sure, ask you all the time, how did you do it? What did you eliminate?
My doctor said that I was pre-diabetic. That was the first thing, scared me, had me taking a shot in my stomach once a week to lose weight. And then she said, keep messing around and you're going to be on high blood pressure medication. So when I came in, she prescribed metformin, tear dropped. She said, when you come back, you're going to be on high blood pressure medication. So I left the doctor's office and I called someone and said, that was my 911 call.
Yeah.
And from that point on, I got serious about it, and I don't eat sugar
I
anymore.
sat next to her at dinner last night, and I can absolutely attest to how she eats. I felt terribly guilty.
What'd you eat for dinner?
A salad. I had a big salad, and I ate some protein. I did.
One of the things that I do with patients after I've done the history and looking at caffeine and looking at amount of alcohol is I just do a 24-hour diet inventory. What did you eat for breakfast? What did you eat for lunch? What did you eat for dinner? And it is amazing. I get so much out of that information. And so what I try to do within that 45-minute visit is give them just some little things that they can do. And sometimes it's little tweaks that add up to a lot. And I don't want to take anything away quickly from people, but I can help them decrease alcohol slowly, help them decrease caffeine a little bit, help them more toward a Mediterranean diet, which starts off really with protein in the morning. So rather than reaching for cereal or reaching for a bagel, what can we find? Can we do Greek non-fat yogurt with some walnuts and some blueberries to get the antioxidants, the omega-3s, the protein, the calcium, trying to show them where they can get the most bang for their buck and stabilize their blood sugar.
I think exercise is also really important, and so exercise doesn't mean training for the New York City Marathon or, but it just means getting out there, getting your heart rate.
Yeah.
And we all know that when you exercise, you get an increase in your endorphins, which is going to make you feel better. And then also, in perimenopause, it's good for your bones and your muscles. So I think, there are some people who love to exercise, that's great. But for people who don't, I encourage all my patients, just go out and take a walk, whether it's a perimenopausal person or someone who's depressed at another point in their life. Just go out, even if you don't feel like it, for 5 minutes, 10 minutes. And little by little, most people will start to see that it has an impact.
There was just a new study, 11 minutes of, moderate to fairly intense exercise. 11 minutes can decrease all-cause mortality and
have to
improve
be able to
mood.
find that in a given day,
Yeah.
right?
Yeah.
All right, let's get to some of the questions because we have about, I don't even know, I can't see, but anyway, we have some time for questions. All right, let's talk queer, gender, nonconforming people with menopause. The menopause movement is heavily feminine. It affects depression. It is disorienting.
I can speak to that. I agree. And I think that we do always talk about women's health and we talk about menopause as a female experience, and that's not true. Anyone who has ovaries will experience menopause and will experience hormonal changes. So I agree that we need to take a look at that. We need to open up our language, and we definitely are very sensitized to that at NYU.
Sure.
In particular, I think everywhere should be sensitized to that. One of the things we do when we see our patients for the first time is talk about how they identify, what is their sexual orientation? Do they identify, are they biologically female, and how do they identify? So I think it's really important to take a look at that right from the beginning. I want people of any orientation to feel comfortable coming to me because anyone with ovaries is going to experience menopause. So thank you for that.
Are there any questions out in the audience right now? Yes. Oh, hold on one second. Let me see if I can do this. Thank you.
Good afternoon. I'd like to know if there's an age limit and or a
Oh, can you
cutoff period.
restart the question? I'm sorry, I
Yeah, we
didn't hear
didn't
the
hear.
first part.
I'm asking about, is there an age limit related to testosterone therapy? When is there a cutoff age, or when would you recommend that that type of therapy starts?
For testosterone, remember, it's for hypoactive sexual desire disorder, so there should be no other indication for it. But no, there's no, you don't have that same sort of position statement on within 10 years of menopause. But it is a hormone, so you need to be careful and talk to your clinician if you're 70 and wanting to think about starting something that is de novo. But there isn't the same cutoff and in terms of how long you should be on it, you might think about trying to come off it after, again, several years. But what we know for low desire is once you come off it, it usually will return to low desire.
One thing we didn't have a chance to really address when you think about, I know you guys are going to talk about this more in the next panel, but this idea of low desire, sexual dysfunction, it can be a consequence of the hormonal changes, but it can also be a consequence of depression, right? And it can also be a consequence of the medications that we use to treat depression. So that puzzle really, it is kind of like a tornado. And so, testosterone is used sometimes to help women when they have, low desire or sexual dysfunction. But I think, again, we want to tease out what's the reason and are there other ways that we can, address this problem for women or even for men who are on antidepressants and they really work and they're having, sexual dysfunction. There are some things we can do. They don't always work, but, you can decrease the dose before you want to have sex. That's not that practical, but you can try to do that. So there are a lot of things, but again, you want to look at the big picture and kind of not just look at one point here or there, because everything sort of falls back on itself and, it becomes kind of a vicious cycle.
Yeah, and I think something that we didn't address that I meant to interject on is the combination of using some of the SSRIs, SNRIs, and estrogen can be extremely beneficial, particularly for perimenopausal women.
We're saying antidepressants
And that combination, because of the way, as we lose estrogen, estrogen really modulates the impact of neurotransmitters in the brain. And I think we brought that up in the first panel. And so they can often work very effectively together, not necessarily for sexual dysfunction, but that we can get a very nice effect of stabilizing hormones as well as improving mood with the two.
Well, also, sexual dysfunction is either going to be difficulty with orgasm, thank you to SSRIs and SNRIs, or difficulty with desire. So it can go in both directions.
Sometimes SSRIs affect your desire too. I mean, it more likely affects your orgasm.
Right,
but-
that's what I said.
Yeah, exactly,
It can
right.
go in
Yeah.
two different directions.
Talk a little bit about the mental adjustments that you have to make when you hit menopause to all of these concerns. I think that's maybe the hardest thing, that you're addressing all of these new changes in your life, and you have to mentally wrap your mind around this new reality that you're facing in all of these different areas. I think that's the most challenging thing, really.
I'm
Urgently tell women to just go to therapy. Just have a space where you can talk about it, where no one will judge you. They won't hold you to this standard that you're expected to hold outside in your world of influence. And part of it is the awareness. You may start talking about something, and then it will trigger your therapist to say, "Are you going through menopause? Or have you talked to your physician about this?" But you're thinking it's just general anxiety, or I'm feeling overwhelmed with things that you've been managing for 10, 15 years, but all of a sudden it just seems too much. There was an episode years ago on Will Smith, Fresh Prince of Bel-Air.
Yeah.
They actually talked about it, emotional balance, with one of the sisters that was going through menopause, and how irritable she was and how she kept going off on everybody. And they just had to take a step back and say, "Girl, you need to go get some help." But who actually says that to their friends or their sister? You're so afraid of offending her. But maybe if we said, "I think you should go talk to someone," and not make it look like you need to go talk to somebody.
Yeah, you're right.
What's beyond that, though, is acceptance. And so that's a subset of cognitive behavior therapy, is acceptance therapy. So you're talking about the struggles of now I'm midlife, now I'm an older woman, and what does that mean? And that really is
Phase of life.
taking some time, and I love to do that in therapy. Well, what does that mean to you, and why, does it need to be, you talked about getting back to you, and sometimes it's moving on and being a different you, sometimes better. I do think that postmenopausal zest is a real thing.
Postmenopausal what? Zest?
Postmenopausal zest.
Zest? When does the zest happen?
I'm in this.
I want to say a couple
I'm
of
in
things.
zest.
I completely agree.
I'm
I
getting there.
also think that as women, we keep a lid on our rage
Yeah,
a
sure,
lot.
Sure.
And I also think we do too much. And I think that menopause is a wake-up
Releases it.
call. It's a wake-up call for us to really say, I need to think about how much I'm doing and how much of it is something I really want to do, how much of it is something I'm doing for myself.
Yeah. Yep.
How much rest do I need? How fast do I really need to go? And do I really need to do all these things? And what am I angry about? And let me take a look at that. So I think that there's definitely the acceptance. I think there's definitely getting help. And I think it's also part of culturally what it is to be a woman and what it means to be a woman getting older in this culture as well.
Because we live in an ageist society, right? So, the representation of going through menopause means you're getting old, and that's a bad thing in our society. But I think, it can be a positive thing too, and I think that's what you guys are saying. So it's not all negative, but I think some of that is also reframing. Like at any transition, when teenagers, when girls first get their period, they're like, oh my God, it can be a terrible thing, but then you can reframe it as a good thing. When postpartum, when women have a baby, the first couple of weeks after it's a stressful, difficult thing, and new moms are often like, I want to just get this baby back, and this is a new phase of your life. So I think we can do the same thing with perimenopause and menopause, but I think we tend to not talk about that as much, and which is why it's a great.
Menopause show.
I know, right?
I think there's a question. Yeah.
Address the fact that the psychosocial thing is real, and that women in this heteronormative construction that we live in become obsolete, right? As we're growing older, and so not only are there physical things that are happening to us, but there are psychosocial realities too. And that brings me to my question. I work with women in leadership positions, and they are seeing that even as managing directors, their roles are shifting a great deal as they go through menopause. And the conversation in leadership and equity and inclusion needs to include the conversation about the realities of menopause. I think we've gotten there a little bit with maternity, but we need to start addressing. So even though we haven't been talking here about the men in the room, we need to start bringing this conversation to the men in the room.
Absolutely.
There's a myth. Do you remember the myth of the empty nest syndrome? Right? That it's a myth. It's really, the idea that women get depressed when their kids leave home. Well, we know that what's the truth is it's not when they leave, it's when they move back in. It really is the.
Though I am encouraged by seeing a room like this with people open and asking questions out loud. I'm working on a documentary, and I've been collecting videos of women, video diaries, and the diaries, people can finish each other's sentence, of what they've been going through through the course of menopause, and then the menopausal zest, which I think is exciting, and it's nice to hear more about that. Which is
Margaret Mead. Margaret Mead coined that term a long time ago.
It's what we need to talk a lot more about for sure. Okay, so this is interesting. Panelists say find experts in New York City, one of the biggest cities in the world. Clinicians barely exist. Nationally, the search would be impossible.
I'm really shocked by that. Wow, because I see so many clinicians coming into the field.
Yeah.
As well, clinicians are being certified across state lines during COVID, being licensed in multiple states. But I mean, it could be that they're stacked.
I think it's a supply chain issue, quite frankly. I feel like what is happening in healthcare is what's happening in so many different industries. And that is that there's this pent up demand of patients seeking care, that want care, demanding care, and we have a shortage right now of clinicians. We had a lot of clinicians that retired. We have people that got burnt out and left. And I think that we need a pipeline of new clinicians, really, to meet this demand. So I think this is a little bit a supply chain issue,
I think
really.
they also went into private practice, which does make it difficult for access of care
yeah.
because private
Yeah.
practice is more
Like a
expensive.
concierge service or
Yes.
something, okay.
Yeah, yeah.
The other question is this, and I think this goes back to what we were asking at the end, what medical practitioners can most likely help. I'm just wondering, is it that people, maybe, I don't know, maybe this doesn't make sense, but maybe we need a title so people understand who deals with midlife menopause. I mean, it's not all OBGYNs that you're going to feel comfortable with dealing with menopause, correct? Some might not, we've already said, some have not been trained in school with it. And I'm just wondering if people get confused because there's not a practice that just says, I deal with midlife menopause.
We have a certification. In
Sure,
North
no, I
America,
understand
right,
that,
so
but I'm
the
saying, but not
NCMP,
everybody, right, but not everybody does. I'm wondering if that becomes more common, do you
Yeah,
think?
yeah.
Or necessary to be more common?
Yeah.
I think, if more people did that, it would make it easier to access the
To
care.
understand who to go to.
Mhm.
Okay, what do you think about the new one-stop shop clinics offering things like MHT and Botox under one roof?
I think they should be separate.
Okay.
And I don't think the answer to menopause is to fix everything cosmetically on the outside. I think we're talking about building things from the inside out.
Okay.
And really working on mental health, things that, maybe aren't visible. So I think, I don't like the emphasis, a place that would do both of those things, to me, is emphasizing perhaps the wrong
Okay.
thing.
Okay,
Didn't we hear in the last
confusing.
panel, if they're selling something and
Okay.
it's kind of, you be
Red
careful.
flag.
Okay. Oh, go ahead.
Okay, hi. I love how everyone is addressing the complex biopsychosocial. I'm a psychologist, and I have recently started a group that it brings in educators to talk to women in various disciplines on menopause. And then we have a therapy group around that. And all of the issues that you're bringing up are top of mind for people, including how do you find the right doc, who's going to listen to you. But I also wanted to raise, I have a specialty in eating disorders, and some of the concerns that I have and that some of my patients are having are tied into what people are talking about in a number of ways. One is, what are the expectations around aging, and how can we shape that so that you're not at 50 and 60 trying to look like you're 30 and then feeling badly about yourself for that. And then also being mindful of restrictive diets that do reinforce some eating issues. And there is another peak, we see it in younger women, and then we see another peak in midlife around eating disorders and exercise compulsions. And so I want to be careful that we're thoughtful about the messaging around weight management. So if you could speak to that, that would be.
I think that's a really
great.
good point as it relates back to your first question, like, why am I not feeling like myself? And to acknowledge that myself changes across our life cycle, right? And so, again, I think that's why therapy is so important, because yes, your body is not going to look the same when you're 50 as when you're 20, whether you have extra weight or you don't have extra weight. And so this idea of acceptance is so important. And the idea of, like, your future. I know there was a question that we might not have gotten to about grief, and grief can play such a big role because people's lives just get changed, right? When they're 40, when you're in your 20s and 30s, most people are fortunate enough that their life is, some people aren't, but kind of plodding along, and you can plan this and this will happen. And then get into your 40s and 50s, lots of things happen. And so, acknowledging that we can pivot and change and that we have this sort of ability to sort of be more resilient, I think is really important. And so therapy, I think, is a huge way, whether it's groups or individual, or, to talk about that.
Yeah, to address those things. Yes.
So one of the things that I think that you're all talking about is helping women advocate for themselves to be the best patients they can be. But one of the things that I think is missing, I'm a systemic sex therapist, and I do a lot of couples. And what I find is a lot of women come in on their own because they feel it's my body, my problem, I'll fix it. And I think one of the missing pieces, and I always ask them, is would your partner be willing to come in at some point because I'm sure there's an impact on your relationship
Right.
and on them.
Right.
And I would love to hear your thoughts about inviting partners into the room when they come and consult with you.
Yeah, we had a really good conversation about it. I mean, just from we're 30 years in this year, and it just got really bad. It got really bad. And that was part of it. I was like, I don't think you understand what's going on here. This is not something that I can control. And so at that point, I think that was a wake-up call for him to say, oh shoot, I did not understand everything that was going on. And it's one of those things with relationships. Do you think that your spouse or your mate is a mate whisperer, that they're just gonna understand everything that you're saying without communicating it? So why are we not communicating about such a pivotal moment in our lives and thinking that we're the only ones that are being impacted about it? And it's not just our spouses, our mates, it's actually our children. Someone asked about the workplace. Like, a lot of people are impacted by your mood shift because they know who you were, and they're thinking, what is going on with her? And so you may lose your job. You may lose your marriage. I want someone to do a study on how many women decide to get divorced during menopause, because you do get to that point like, I don't have to deal with this anymore. The rage.
I was just I think there's the flip side of it too. So when you have someone who's coming in and saying, my body's so different, I don't feel appealing, and talking about bringing a partner, and sometimes women are surprised because partners aren't really impacted the way they think they are, which kind of goes back to the eating disorder question, right? So, we can have all these fantasies about how we should look or how we should be and how that might be negatively impacted. And unless you have the actual data from the partner, you don't know, is it worse? It could be a period of time that's worse, but it could be a time where you're bringing all that on yourself, and it's really about the communication. So I don't know if you see that too, but I think that could happen also.
If there is a partner.
Yeah, or if
They're not always a partner, not always the same gender.
Right. Go ahead.
I am a physical
Can you
therapist.
put the mic closer to your mouth?
Yeah,
Thanks.
sorry. Good morning. I am a physical therapist, and I specialize in women's health and pelvic health. And thank you. And we are a growing field across the nation and across the world. And mental health therapy and physical therapy has a great opportunity to be covering all of these things. I feel a great privilege in being able to bridge the gap between the 22nd MD appointment and the struggles that are happening in real life. And because we have a little longer time available to be able to work with our patients and listen for an hour session, 40-minute session, whatever, we can really be that person. I hear the access difficulty and who do we tell? But this is an opportunity between mental health therapists and physical therapists to be able to tell your story, and we can perhaps help you then triage to the right people or to some of the strategies available. And physical therapy has the great ability to be able to treat head to toe and all between. That's my kind of personal slogan. But
pelvic floor physical therapy has changed our world. Yeah. Really, it has. Pelvic floor physical therapy, and we'll talk about it in the next panel. So thank you for bringing that up.
Yeah.
Absolutely.
To her point, I'm also a physical therapist, board certified in women's health and certified in pelvic health. We do a lot for the pelvic health. And I think what she's saying is that holistic point of view of wellness, how to keep the muscles, the bones strong, beyond pelvic health.
Sure.
So
The more than one thing.
With the American Physical Therapy Association, and physical therapists are on this. I mean, they are on the menopause bandwagon, and we keep pushing it. So know that we are on it.
Yay.
I want to ask this one question because you addressed divorce and women in work. Somebody said this, and I'm curious what you think. There's ageism in the workplace. Isn't addressing menopause at work biasing women even more?
It's an interesting dilemma.
It is.
And the UK is addressing it before we are.
Yeah.
And they really are working towards having a policy that will protect midlife women and menopausal women. And it is, will that create more bias to the leadership, or will it protect? My hope is that it will be more protective, that we have terrible maternity health policies in the US. We're the worst country. And we have terrible midlife policies. So I get it that it may look like, well, we have, they're weaker, but I do think having those policies in place that allow for changing the temperature or how you dress or time off, I think can be very helpful.
Yeah, I do too. I know I'm in the process of working on some of that kind of stuff myself, and I'm curious about that because I look, it affects you at work, and we're working later and later in life, and we are in a prime of our career, oftentimes as we're battling a lot of these unknowns, a lot of this transition. Okay, what is cognitive behavioral therapy? Someone's asking.
CBT, cognitive behavior therapy, really is it's relatively short term. It's very pragmatic. It's looking at how your thoughts and feelings and behaviors impact your mood or anxiety, and shifting them in a way that can change both, psychologically and even with neuroplasticity will change how brain function is to improve mood, anxiety, sexual function. So it's very pragmatic. It really is about challenging some of those very ingrained thoughts and beliefs that you don't even know that you have, that are sort of automatic, and helping you see them and challenge them and then shift them into a more positive direction.
All right. Let's do one more question because then I'm getting a wrap. So, right in the yellow scarf, or is that yellow? I can't. Green? I'm sorry.
Can't hear.
Can you speak up louder? I don't know if there's a mic.
Menopause affects half the population, and every internal medicine, every primary care doctor, half of their patients will probably experience it. Every gynecologist, unless they specialize in obstetrics only, will have menopausal patients. So on the side of medical education, I actually think we need to reform our medical education and training systems so that everyone in these primary care specialties can handle basic menopause. And yes, there is a lot to it. So we cannot be psychiatrists and pelvic floor physical therapists and marriage and relationship therapists all in one, but we should be able to provide basic menopause care, leaving the specialists to handle the really difficult cases.
Thank you.
And I think, we're not there yet. There's a lot to be done. There's a lot of systemic barriers to that because unfortunately we have a medical system that rewards procedures and 15-minute visits and single prescriptions, and you cannot do menopause like that. So before we get there, I think my sort of advice would be and I think somebody said it on the panel, to really prepare for that visit. There is a lot of information online. Some of it is good. Some of it is not so good. There are platforms that are listed here. And again, full disclosure, I do have the privilege of working with one of those platforms, Electra Health. But there is valuable information out there. And if you access it and bring it with you to that 15-minute appointment, it's going to be that much more effective for you.
Thank you so much. I think on that note, I appreciate everyone's questions. I know we have more panels today, but thank you all for being here and being so open and answering questions that are just, coming in. I appreciate it. Thank you.